Welcome, welcome to the return of the real big capital R. We never told you, but RLR is spelled with one small R, yours truly, and the real R, the capital R, Prof. Rez, who is back. We've missed him. I think, it's been a couple of weeks, right? Because of travel to Geneva, or no? Did we have one in the middle? Help me out. I'm lost today, man.
Well, we canceled one together,
Yeah.
and then I missed the second one,
Right.
and
So
now we're here to make magic, baby.
yeah, let's do it. It's been 2 whole weeks since we've um discussed. So really excited to see you all today, and thrilled that our dear friend Sammy actually has a case prepared for us. So without further ado, let's hear from Sammy and then Prof. Rez.
Hi everyone, my name is Sammy. I will be presenting the case today. I'm so looking forward to have RLR discuss this case. I enjoyed it a lot and I hope you guys do too. So if we get the whiteboard up, I can start. Or I can also start before that. All right, this is a 62-year-old man with fatigue and yellowing of the skin since 1 week. He also states that his urine has become darker in this 1 week, and that's the first aliquot.
So, it's so interesting. This can only be one possibility, and that's that this patient has ingested too many carrots. Am I seeing any laughter? Maybe just a little bit. I guess that's almost like a dad joke where people just don't laugh. It's really lame. But let me give a quick assignment to the audience. There's one condition in medicine where you can get scleral icterus in one eye. What is that? But now let's get to the case, Sammy. First of all, I'm so excited to co-discuss with Robbie. And I always get a little nervous when I see Sammy as the presenter, because usually it takes us on this really wild journey where I learn a lot from. But now, jokes aside, what is the problem we're solving? The problem we're solving is jaundice. And jaundice should be converted into hyperbilirubinemia. And that's what we're trying to solve here is hyperbilirubinemia. Immediately, you can think of life-threatening causes like you do for chest pain or as you do for pleuritic chest pain. For hyperbilirubinemia, that includes acute liver failure and cholangitis, and maybe severe forms of hemolysis. Now the question becomes, can we make any progress before any of the labs are back as to whether this is direct or indirect hyperbilirubinemia? And I will pose that question to the audience as I discuss it in real time, but please share your response in the chat box. The dark urine that Sammy told us about is a very helpful clue. Because if you ask the question, what form of bilirubin actually makes its way to the urine to darken the urine, it's the direct form of bilirubin. That's direct hyperbilirubinemia. Because the indirect form is water insoluble, so it actually doesn't make its way to the kidney to darken the urine. But you have to be very cautious here, folks, because you can easily imagine that this patient is sick, is not drinking water, and is just hypovolemic and has concentrated urine, like many of the residents that are working in the hospital where they go without drinking any fluid for a prolonged period. So you have to be open to the possibility that the dark urine is unrelated to the hyperbilirubinemia. And if it's unrelated, it prompts, the possibility of hypovolemia. But then the question becomes, can you have dark urine and indirect hyperbilirubinemia? Yeah. And for that, let me pass the mic to Rob, because he recently discussed a case on RLR. And I just think it's such a fascinating question. Like, can you have hyperbilirubinemia and dark urine not related to hypovolemia?
Oh, the answer is yes, Prof. Rez. Thank you for the alley. The cause of dark urine in patients with indirect hyperbilirubinemia eliminating concentrated urine is not the bilirubin itself. it's a molecule that's closely related to the bilirubin, making the increase in indirect bilirubin, and that's hemoglobin. So the scenario would be that the patient has intravascular hemolysis, resulting in hemoglobin coming into the urine, darkening it. And at the same time, that hemoglobin is being processed and decoupled to indirect bilirubin, which results in the dark eyes and the darkening of the skin. So in all comers, we assume that the color causing the eyes and the skin and the urine to change is the same. But this goes to show you in medicine that sometimes there might be multiple separate explanations for two rare things. The skin is dark because of the indirect bilirubin, and the eyes are dark with the indirect bilirubin, and the urine is dark because of something else, either concentrated urine, more likely, but more importantly, the presence of intravascular hemolysis, which was the answer to the case. Amazing start, Prof. Rez. Sammy, tell us more, please.
All right, great discussion. It's already very a lot of pearls when half of the teaching points drop, box is already filled. So I will continue. Review of system is negative for fever, dyspnea, cough, abdominal pain, nausea, vomiting, any changes in stools, and also stool color, and no dysuria. For his past medical history, he has type 2 diabetes mellitus, hypolipidemia, and had cellulitis 3 weeks ago, for which he received treatment with Bactrim 2 weeks ago. Medications otherwise include pravastatin, insulin glargine, insulin lispro, and naproxen PRN. He does not have any allergies. He denies smoking or illicit drug abuse. He drinks 5 beers per week, denies intake of any herbal substances. For his family history, mother has type 2 diabetes mellitus and father has a history of pancreatic cancer in his 60s. Otherwise, no animal exposure, hasn't been sexually active for the last 5 years, no recent travel, and he works at the garbage disposal.
Amazing. I'll just share some thoughts, then pass the mic to Prof. Rez to mop up after I give it a shot. And I will say that right now we're tracking which of the two H's is at play, heme or hepatic, and both of them are plausible. So let's see if we can make some connections with either of them. The hepatic hypothesis is always more probable than the heme hypothesis, simply because liver diseases are much more common than hemolytic diseases. So let's start with that. Whenever you're entertaining the world of hepatic or liver, the time course of the disease is important. Is this cirrhosis or is this acute liver injury? A topic that came up for Prof. Rez, we recently emailed about it recently. And so we don't know that yet, but if this person has chronic liver disease manifesting, then his type 2 diabetes and hyperlipidemia become very relevant for the possibility it could be related to NASH or non-alcoholic steatohepatitis. If we're dealing with acute liver disease, then the medications are closely scrutinized as they're one of the most common causes of acute liver injury. And here the culprits might be the Bactrim, unless less commonly might be the statin. There's a very rare association between type 1 diabetes and insulin that Sammy taught me, ironically enough, called glycogenic hepatopathy, which probably isn't at play because of the patient having type 2 diabetes. That's really the reflection on the medications, the medical history, and the social history is telling here, but more important is the health-related behaviors and wondering how much alcohol use. The patient's reported use of alcohol is one variable, but in all comers, that variable can be inaccurate. So tracking for other markers of alcohol use, including the MCV, the AST-ALT ratio, is going to be important. Prof. Rez, thoughts?
I'm just thinking about Sammy and this type 1 glycogenic hepatopathy. That's incredible. Sam, we had a case of that at Hopkins like 5 years ago, and it was such a cool DX to make.
All right, so we will proceed with the physical exam. So on physical exam, he was afebrile. Vitals were within normal limits, but he had prominent jaundice. For his hint exam, his conjunctiva were ecteric, otherwise no pharyngeal erythema, exudates, or ulcers, no cervical lymphadenopathy. Cardiovascular exam, normal rhythm, normal heart sounds, no murmurs, rubs, or gallops. Abdominal was soft, non-tender, non-distended. No hepatosplenomegaly palpable, and pulmonary, he was clear to auscultation bilaterally. Skin exam, he had no rashes, normal skin turgor, but he was massively jaundiced. Neurologic, there was no focal neurologic deficit. He had no palmar erythema, no telangiectasia or spider angiomas, I'm sorry.
That's great, Sammy. Incredible and physical exam, thorough presentation. I'll be brief here. I think, you know, we're tracking the hyperbilirubinemia. The lack of fever and abdominal pain significantly lower the likelihood of cholangitis. And that's something to seriously consider in someone who has a history of diabetes and is immunocompromised, because that can be a life-threatening condition. The other thing we notice is that this patient doesn't have encephalopathy to suggest, you know, impending acute liver failure. Now, if we just use Robbie's framework of heme versus hepatic, what about the physical exam helps us make progress? Unfortunately, not much. If something were present, for example, if you had splenomegaly, then you could say, well, that could be related to hemolysis, extravascular hemolysis through the reticuloendothelial system, but it could also be related to acute liver injury and portal hypertension. If we found like abdominal pain, you might prioritize hepatic, but you still can't rule out hemolysis, where then you can have cholelithiasis. So I'm really struggling, Robbie, and I would love to hear your thoughts. Can you, with this exam, make any more progress for the heme versus hepatic pathway that you started out with?
I love that question. I think it's an amazing exercise to try to do. And you might ask it in the most extreme form, which is to say, hey, do we not even need to fractionate the bilirubin because we can predict based on now? And I'd say the answer is heck no. I don't think so. I think what are the situations where you might have an educated guess? I think when the patient has evidence of cirrhosis on exam, if we had that, then I'd be like, you know what? Okay, I'll believe it. I think it's direct. And if it costs me $1 million to fractionate it, maybe I'll skip that step. But short of that, I don't think you can. I'm going to track this hypothesis that I don't know the answer to, so I won't say it as certain. But I'm wondering if the degree of jaundice helps us make some progress. So if somebody is so jaundiced from a hemolytic anemia, do they really have normal vital signs and normal and no dyspnea? I've never thought of it before, so I can't claim to have studied it, but I'll use this case to see where that hypothesis lands.
And Robbie, tagging on that, like we know that hemolysis alone should not cause the bilirubin to go above 6. And here with Sammy giving us this picture, I'm thinking it's going to be north of 6. Yeah. And therefore a non-heme related process to be more likely, which would also explain that initial dark urine that this patient had.
Love it. Sammy, please only give us the indirect bilirubin, okay? Nothing.
All right. The indirect billy was, I need to calculate. I will just give you the direct. It's 18.9.
Rule number 1, Prof. Rez is always right.
Hey, Robbie, who does this? Zhoo! No, Sue!
Wait, what? I have no idea what you're talking
like
about.
Imagine me jumping up doing a
Ronaldo. Does he make that sound?
Well, I'm probably saying it wrong. He says "see," but then it sounds "sue," "shoe."
Oh, really? I didn't know that.
You see, Yasmin knows what it's about.
All right.
Yes. All right, Sammy. We'll let you keep going.
For the rest of the labs, his leukocyte count was 10.5. So 10,500 with 75% neutrophils, 15% lymphocytes, 10% monocytes. Hemoglobin was 14.7, hematocrit 45.6, MCV 84, platelets 311,000. For BMP, his sodium was 114, potassium was 4.2, BUN was 9, creatinine was 0.63, glucose 260, albumin was 3.3, total protein was 6.7, INR 1.1, amylase 64. And proceeding to the hepatic labs, ALT was 425, AST was 211, alkaline phosphatase was 1,515, and total bili was 25.8, and the direct was 18.9. One thing I've learned from you is never do math in front of a crowd. So what do you think?
Prof. Les, let's divide and conquer. Y'all, if you haven't checked it out, Prof. Rez put out an incredible video for SIADH on Twitter. It's the most concentrated epic teaching in 2 minutes I've ever seen anybody do. And it may be relevant with the sodium, it may not be, who knows. But Prof. Rez, you should tackle the sodium and I'll tackle the liver stuff. And then please add on to the liver stuff that I'll start us off with. But before, Sammy, one quick clarification. I heard you saying the diff, but I was actually making a quick note in Evernote to track later. What was the diff?
Basically unremarkable.
Okay.
75% neutrophils, 15 lymphocytes, 10 monocytes percent.
Perfect. The reason I asked is I heard you say the lymphocytes, and I wanted to make sure we didn't miss lymphocytosis to suggest BD or a cancer, but that's not the case here. Let's see the liver. We first confirmed that this is the hepatic hypothesis, and now we know that the liver itself or its plumbing is not working. So if you're thinking about jaundice, you can get it actually in a very simplified manner. Heme hepatic as your first branch point, and then with hepatic, it's another 2 branch point, intrahepatic or extrahepatic. Now let's do the same exercise that Prof. Rez encouraged us to do with predicting if it's heme or hepatic in the first place. Let's try to predict if it's intrahepatic or extrahepatic. How can we do that? The degree of liver enzyme elevations will be helpful. Now, let me be more clear. There are 3 liver enzymes we use: AST, ALT, and alkaline phosphatase. The higher the AST and the ALT, the more chances that the patient has an intrahepatic disease process. Why? There are almost no AST or ALT in the extrahepatic biliary tree. And so the higher they are, the more likely you're in the liver itself. It's no different than using a urinalysis to predict intrarenal AKI. The more proteinuria and hematuria, the more likely it is glomerular in origin, because the glomerulus is the only thing that secretes albumin and red blood cells. Some of the tests can be noisy, so the higher it is, the more impressed you are. I would say these are not super high, but impressive enough to make me guess that it's probably a little bit intrahepatic more than extrahepatic. But there are a couple of other clues to help us make that educated guess. And that would come from really analyzing the sodium, not in its detail, which I'll pass to Prof. Rez, but just as a clue. Most people with extrahepatic disease have stones, strictures, or tumors, none of which are prominently associated with mechanisms causing hyponatremia. In stark contrast, many intrinsic liver disease are associated with hyponatremia. So I'm going to say that we need, just like we needed to fractionate the bilirubin, we need imaging to tell us for sure. But if I need to practice my prediction skills, if imaging is delayed, as an example, then I'm going to say that AST, ALT are high enough. And the fact that there is a distant disease, the sodium, is making me think it's more likely to be intrahepatic than extrahepatic, but I would give it a 60-40 confidence, just slightly above a coin toss. What are the implications for that? The implications of that hypothesis generation now is scrutinizing the alkaline phosphatase. The height of the alk phos is very impressive. It may clue you to reverse your guess to say, wait, no, the alk phos is this high. So it has to be extrahepatic. But how can you have a super high alkaline phosphatase in lieu of an intrahepatic disease? It's when there is an infiltrative intrahepatic disease process. Now, why does that happen? For that, you have to close your eyes and follow the biliary system. The biliary system becomes microscopic and small and lives in the liver diffusely. So instead of having a big pancreatic mass blocking the major extrahepatic duct, you can have the exact equivalent happening on a microscopic scale, diffusely scattered throughout the liver. Take all that cancer of the pancreas compressing on all that bile duct and spread it out diffusely in the liver, and you have the exact same pathophysiology. So the constellation of these findings has me slightly prioritizing a diffuse infiltrative intrahepatic disease over an extrahepatic biliary compression. Either way, the biliary tree is compressed, and the question is where. Imaging is definitive. The AST, ALT, and the hyponatremia suggest that it's in the liver itself. Prof. Rez, let's hear some sodium magic and any other clarifications you have about the liver stuff.
That was incredible, Robbie. You taught with such clarity. You really took us down to the small little intrahepatic biliary duct. I was there and looking at my environment and seeing the hepatic parenchyma. That was really, really good. Sammy, before I actually comment on the sodium, do you have a serum osmolality?
No, not yet.
Not yet. Okay, so then we'll just work with what we have. When you're evaluating hyponatremia, you always have to ask, what is the level of its best friend? Who is sodium's best friend? Type it in the chat. Sodium's best friend is glucose, because you have to correct the sodium for the degree of hyperglycemia. And here, for every 100 rise in glucose, you can increase the sodium by 1.6 to 2, let's say 2. So even when we correct for the 200 rise of glucose, and I am doing math, Sammy, you would go up by 4 on the sodium, so you're at 118. So you're still quite hyponatremic. The most common bucket of hyponatremia is always going to be hypoosmolar hyponatremia. And osmolality should be checked in all patients with hyponatremia before even doing a volume status exam, because our volume status exam is not perfect, especially when you're dealing with euvolemic versus hypovolemic hyponatremia. One thing that's super fascinating is that we're not seeing any symptoms of this patient's hyponatremia. Those symptoms could be nausea, confusion, seizure, etc. And this tells you to the chronicity of this underlying disease, that it's not happening hyperacutely. This is happening probably subacutely, whatever it is we're dealing with. So when you send the serum osm in this patient, you have to be cautious in general, because here the glucose is quite high, so that may contribute to the osmolality. So before you say, oh, this is isoosmolar, you have to make sure you subtract, the glucose divided by its molecular weight when you're trying to frame this. So the next steps in evaluating this patient is going to be a urine osmolality, because we need to know, is ADH on or not. Here, we're going to expect the urine osmolality to be high. And if the urine osmolality is high, then the final step in evaluating hyponatremia is to look at the urine sodium. Because when you have states where you have decreased effective arterial blood volume in the context of heart failure, cirrhosis, hypovolemia, you're going to activate the renin-angiotensin-aldosterone system, and the body is going to want to keep all the sodium it possibly can. So you have a low urine sodium. We have no evidence of any of those conditions. And this sodium is just too low, honestly, for it to be decreased effective arterial blood volume. We are most likely dealing, if we were making a bet here, we're probably dealing with hypoosmolar hyponatremia with a high urine osmolality and a high urine sodium. And then this goes back to what Robbie was saying. So if we apply that, we say, well, what can cause that picture? It's adrenal insufficiency, it's hypothyroidism, it's renal insufficiency, cerebral salt wasting, or SIADH. But if we wanted to make everything sort of nicely come together, you would think SIADH, and then in the context of SIADH, you would think some form of like infection. And then if you wanted to play off Robbie's hypothesis, could this be a granulomatous infection that's infiltrating the liver and also causing syndrome of inappropriate antidiuretic hormone? I'm not going to activate the schema for granulomas yet because we've already made way too many leaps before even getting a serum osmolality. So I just we got to get more data from Sammy to verify that is this SIADH or not, and then we can, go from there. But that sodium is really low, and it really makes you think, is there something other than our typical etiologies for hyponatremia?
Wow, what a journey from the periportal space down the urine and the electrolytes. I just love it. Thank you so much for that. So the next aliquot will be very short, and maybe Reza, you maybe want to just keep going on that. So the serum osmolarity was 290. He received a sonography of the abdomen, which showed only steatosis hepatis. So otherwise, the biliary tracts were non-dilated. The bile, I'm sorry, I'm blinking on the term. There were no signs of cholecystitis, no high drops of the gallbladder, and the pancreas could not be seen.
All right. Well, this is really interesting. And since I just, spoke for a significant time period, let me pass the mic to Robbie to see what his thoughts are.
Prof. Rez, you set us up for success here because you so aptly emphasized how important it is for the serum osmolarity to be checked in these patients. And to take a minute to explain the reason for that. The reason for that is to not make the assumption that sodium is the predominant osm. There are some situations where the sodium is not the predominant osm, like glucose. And there are some situations where the measurement of the sodium is interfered by certain substances. So now we have a very specific syndrome to study the differential for, is we have eusosmotic hyponatremia or isoosmotic hyponatremia. What's the DDX for that specific condition? The first is to, again, not be misled. Isoosmotic hyponatremia can occur because of a combination of hypo and hyper, averaged out, again, doing some math for you, Sammy, to be eusosmolar. Is that possible? Maybe. Let's run the DDX for hyperosmolar to make sure. Is it glucose? The glucose is not high enough, as Prof. Rez told us. Is it mannitol? The patient hasn't received any. Is it contrast? The patient hasn't received any yet. Is it urea? The BUN is 9. Is it alcohol? Probably not. This patient would be intoxicated. So we're probably not dealing with a combination of hyper and hypoosmolar hyponatremia. So what causes true isotonic hyponatremia? And that really comes down to hypertriglyceridemia and hyperparaproteinemia. The total protein here is only 6.7, raising concern that this person with a history of hyperlipidemia might have hypertriglyceridemia. So my immediate steps would be to get a triglyceride level to see if we can use that as our anchoring hypothesis. There are some unusual things here. It's very unusual for a patient to have this degree of hypertriglyceridemia and not have some evidence of grossly lipemic serum on collection, but that can be easily overlooked. But I think if you look at the picture now and say, what is the pretest probability of hypertriglyceridemia? I would say it's decently high because the patient has type 2 diabetes, hyperlipidemia, and is on a statin. The holes in that hypothesis are, why is the serum not grossly lipemic? And then it begs the question, okay, well, can we trust now? If we can't trust the sodium, can we trust any other lab abnormality here, or are they all erroneous lab abnormalities? The bilirubin is definitely plausible because we can see the effects of that on the skin. But what's causing these? Now you have to scrutinize and recognize that when the triglycerides are high, if they are, that you can't trust any lab, and that you have to rerun these labs with a pheresis of the triglycerides. So we have to slam the brakes now, because we could be so fooled. And there are two reasons for us to be fooled. One is Sammy presenting a case, be careful. And two, triglycerides can mess up most of your laboratory analyses. Thoughts, Prof. Rez?
Man, I'm a bit stumped, to be honest with you. I don't really feel too confident as to like what the final diagnosis is. I think that checking a direct, like a direct electrode sodium, where you're not actually measuring it as like the way it typically is done, is you take like the serum sodium over a volume, and that volume does not discriminate between protein and fluid, but rather it's called a direct electrode method of sodium. So I think that's going to be an important step. Let me ask you, Robbie, with the triglycerides, and how do you link that back to the alk-phos and AST and ALT? Because if you have, like, if we think fatty liver disease and NASH, that I don't really associate with these types of liver chemistry tests, you know? So I guess I'm having a difficult time, unless there's a condition we just don't know about, like, you know, of this infiltration in the liver. How are you reconciling those two facets? Because we were solving one problem of this really abnormal liver chemistry panel and jaundice, but now we're trying to solve another problem of like isotonic hyponatremia. And I'm just trying to connect the two dots together.
I think we can definitely, I'll tell you where I'm at. I don't know what the probability of the triglyceride hypothesis is, and my mind is putting the brakes on until we know that. But if we assume that it's high, then honestly, I don't know what lab tests we can trust. I don't know what the person's actual AST, ALT, alk-phos is. And there's two reasons for that. I know that the triglycerides just mess up the labs, but I don't have enough knowledge to tell you which labs it messes up. So we could just Google it now, but I'm trying to stretch my reasoning and just trying to go in blind to learn from mistakes that I will inevitably make, because I don't know this. But I just know triglycerides mess up your labs.
Yes.
I don't believe that they're going to mess up somebody who's looking jaundice. So I believe there's some issue. I just don't know what that issue is, you know? Yeah, that's where I'm at.
And so I think like I'm right there with you. So we check the triglyceride. What's true is the jaundice. Like we know this to be true. Hyperbilirubinemia is true, and that needs to be explained. So right now that we're still really concerned for the liver. So the next test is an MRCP and considering a liver biopsy to better elucidate the underlying pathology, and then working up this hyponatremia on the side as well.
Amazing discussion. I love you both discussing through that case. So we'll give some more information. The urine osmolarity was 564. Urine sodium was 66. Urine creatinine was 36. Hep A, B, C serology were all negative. ANA, anti-smooth muscle antibody, AMA were also negative. SPEP revealed no M spike, no signs of hypergammaglobulinemia. Light chains were also within normal limits. And MRCP was performed, but had to be stopped due to nausea of the patient. But that what they could see, it was within normal limits. Yeah, and the next test will reveal a final diagnosis.
Okay, so, you know, I don't know what to make of this serum osmolality. Let's like, because everything else is like, You said the urine sodium was 31, Sammy, is that right? Or what was the urine sodium?
The urine sodium was 1 second.
66. Thank you, Alec.
66, yeah.
Yeah, so like if you look at these lab results, it's really like suggestive of like an SIADH picture, except the serum osm. So the question is, how accurate is the serum osm? And at the end of the day, I would repeat the serum osm. And okay, I'm seeing Alex said just ignore the serum osm. Okay, if we ignore the serum osm, then we're dealing with an SIADH like picture. And then a way to link everything is back to our initial hypothesis of some kind of granulomatous like infiltration of the liver that's also causing SIADH. When you're dealing with SIADH, you just have to quickly make sure there's no physiologic stimulus. And this patient really doesn't have one, like pain, stress, etc. Then you review the med list, and none of those meds cause SIADH. Then you look for pathologic stuff like the pathologic stuff, including cancers like small cell cancer of the lung, pneumonias like Legionella, CNS disorders, or infections, any kind of infection. I do think that like my next step in this workup would be a liver biopsy because we've ruled out like the extrahepatic stuff, and it's just really high level of alkaline phosphatase. Of course, we'll be following these liver chemistry tests and seeing how the patient is doing. But if this is, for example, drug-induced liver injury, the prognosis is poor for this patient based on the degree of hyperbilirubinemia. So, Robbie, where I am is like, I just don't know how to use the triglycerides to explain the jaundice. So I'm like tabling off that possibility of isotonic hyponatremia. And my focus is on the liver and intrahepatic cholestasis and trying to identify why. Yes, it could be drug-induced liver injury, but like just the severity of it and the height of the bilirubin would prompt me to want to pursue a liver biopsy just to make sure there isn't something else happening. But I don't know what your thoughts are.
Well, I think we can both. Only thing we can both confidently say is we're going to learn a lot from this case. I cannot tell you a diagnosis with confidence. No chance. I just want, Sammy, can you clarify one thing? When you say the MRCP, does that include, with the limitations that you described, also assessment of the liver itself? Did the liver also macroscopically appear normal?
Yeah, findings consistent with fatty liver, but
yeah,
nothing otherwise abnormal.
Perfect. Yeah, Prof. Rez, I think I'm just going to practice starting, like saying how far I can take it, and then just say, good luck. Let's learn from Sammy.
Never mind. I have one more aliquot.
Oh, you have one more aliquot.
Yeah, I can make it one more.
Oh, thank gosh. Whew.
Okay, are you ready?
Let me tell you one thing. Where do we stand? This problem is in the liver for sure now. MRCP is better than the ultrasound. So this problem is in the liver, and it appears to be of the infiltrative type given the alk-phos. So I think the hypothesis there's something diffusely infiltrating the liver is very probable. So let's share an approach for that. What causes diffuse infiltrative liver disease? Before you start to answer that question, I think Prof. Rez, I'm going to make a video for this for RLR, for the website, because this is such a fun topic. Before you start to answer that question, you need to answer one question, which is, am I worried about local infiltration of the liver alone? Or is there evidence of a systemic disease infiltrating the liver? There's no lung issue here. There's no evidence of anything else going on in the systemic circulation. So either we're dealing with an occult systemic disease, which is very unusual to cause this degree of liver injury. So I'm pretty worried about a local infiltrative disease process. Now, what the most common version of that is infiltration by fibrosis because of cirrhosis, a local infiltrative destructive disease. What's the other one? The other big category is fatty infiltration. Non-alcoholic steatohepatitis, acute fatty liver of pregnancy are prominent examples of this phenomenon. There are other infiltrative diseases of the liver that are locally affecting the liver itself, including what Sammy taught us, glycogenic hepatopathy. There's local glycogen accumulation. So I'm a little worried that that this patient has a local infiltrative disease. I agree with you that the best way to diagnose those things is with a liver biopsy. I'm tempted to say that if the patient has systemic hyperlipidemia or hypertriglyceridemia, then I would prioritize the fatty accumulation. But I think confidently saying this patient has some infiltrative liver disease, and 70-30 saying it's a local disease. But we'll see what Sammy teaches us.
All right, amazing discussion. So workup for SIADH was unremarkable, normal chest X-ray, no pain, and nothing that could trigger ADH secretion, thyroid, and adrenal tests were within normal limits. Liver biopsy was performed as you requested and revealed findings compatible with cholestatic drug-induced liver injury, no signs of granulomas or any other infiltrating disease. Total cholesterol was 1,663 and triglycerides were 584. And that's all you get. What do you think?
Oh, I'll just share my thoughts. I think this case is amazing. My best guess is that there are 3 things happening at the same time for this patient. The patient has underlying hyperlipidemia and is vulnerable to impaired issues, is vulnerable to a second hit hypothesis that impairs their lipid clearance. How can somebody get hyperlipidemia or hypertriglyceridemia as a second hit? They consume alcohol, they have hypothyroidism, they have nephrotic syndrome, or they have extrahepatic, or they have cholestatic liver disease. So my best guess is that this person has underlying hyperlipidemia, got Bactrim-induced cholestatic biliary obstruction on a microscopic scale, and that biliary obstruction further worsened their triglyceride levels, causing isotonic hyponatremia. So I think they have underlying hyperlipidemia. You then got an acquired form of hyperlipidemia by blocking the lipid excretion through the liver. And that's my best guess. I'm totally making it up. I have no idea if it's real or if it exists, but it's the most sense I can make of the data that Sammy has given us. Prof. Rez, how are you putting it together?
No, I really love that hypothesis. And I think that I just quickly Googled Bactrim and SIADH, and apparently there can be a link. So I'm not necessarily sure we've completely ruled out SIADH here, and a serum uric acid would be helpful. So this could be one of those things where you have both hypoosmolar hyponatremia and isoosmolar hyponatremia and a little bit of hyperosmolar hyponatremia from the hyperglycemia. But regardless, I think the main pathology here is drug-induced liver injury. And there you can use Hyde's law. I don't know about how great its performance is to sort of predict prognosis. And again, I think this high bilirubin is a concerning feature in someone with drug-induced liver injury. So this is a patient, rather than just stopping the offending agent, which has already been stopped, which is the Bactrim, considering immunosuppressive therapy in the form of steroids, which would worsen the triglyceride and the diabetes and stuff. But I'm curious to learn from Sammy how they put this together, and also what were the next steps in management and control of what seems to be drug-induced liver injury.
Amazing discussion. Thank you both so much. I learned so much listening to you. So they pieced it together as a pseudo hyponatremia due to lipoprotein X, due to the cholestasis secondary to the drug-induced liver injury. They didn't measure it. There is like this lipoprotein X that can accumulate with cholestasis and can cause a pseudo hyponatremia. So it isn't a real one. The tonicity stays the same. You also shouldn't fluid deprive these patients because they have increased viscosity. And when I heard about this case, it was just so humbling for me, because yeah, I never would have thought about it. It was very complex, but I have just some teaching points about pseudo hyponatremia that I mostly learned from you guys. So as the chat mentioned, you can have hyper and hypo or smaller causes, like both occurring at the same time, causing a normal serum osmolarity. And then you have three other things. Either it's hypertriglyceridemia, or which mostly happens in the diabetic ketoacidosis, or familiary hyperlipidemia syndromes. Secondary is like B cell dyscrasias that secrete polyclonal or light chains and antibodies that interfere with the assay. And the last is lipoprotein X that accumulates with cholestasis. And that's like an abnormal lipoprotein particle of LDL that actually reduces its atherogenicity by preventing its oxidation, but it also causes this false low serum osmolarity. Yeah, and I found this case very interesting, and I wanted to present it to you guys, and I think we all learned so much, so thank you.
I'm just blown away. Really, really great case, because we never usually find ourselves in that middle bucket. So to have an exercise to think about it and then to refine our skills is really helpful. And Sammy, did you, before Robbie reflects, did you guys do anything for management wise, like anything other than just monitor?
I didn't see this patient, but I think he got better. That's all the information I have.
Sammy, I never thought, I think the very notion of pseudo hyponatremia kind of gives you this reassurance that, oh, there's no problem here, you know, but that's so wrong, you know, like I always just think, what's the point of pseudo hyponatremia? It's like it's just not a real thing. But you're teaching us how important it is to pick up on discrepancies, and discrepancy between a high calcium and a normal PTH, a discrepancy between a low sodium and a normal serum osms. Discrepancies are often the key to solving problems. And those discrepancies may be inherent physiology or an artifact of how we measure things. Another favorite example is when you have a normal serum lactate and a high point of care lactate. That's ethylene glycol toxicity as an artifact of how we measure things. So I will be inspired so much by this case to continue to try to explain those discrepancies, but also learn something I've never even heard of before, which is pseudo hyponatremia from lipoprotein X. So thank you. And I will be deep in my nerdy thoughts this Friday night while the whole world is partying and having a great time. And I will be thinking of you, Sammy. Appreciate it. All right, Maddie, you have the somehow I'm going to summarize all the teaching in this case.
Yeah, I'm not going to miss one thing, no. So what a case, and just so much learning. I think I could have taken up this whole whiteboard with teaching points. So I will try to summarize and do this case justice. So we started with jaundice, and we learned that we can convert jaundice into hyperbilirubinemia. And we reviewed the life-threatening causes, which can include acute liver failure, cholangitis, and severe hemolysis. In addition to jaundice, another initial presenting symptom was dark urine. And we initially thought about this, is this related or unrelated to the hyperbilirubinemia? So examples of how dark urine could be related, this could be from direct hyperbilirubinemia, because direct bilirubin is water soluble and actually makes its way to the urine. Or actually, it could be the result of indirect hyperbilirubinemia, and a mechanism for that would be intravascular hemolysis, leading to hemoglobin making the dark urine. A way this could be unrelated to the hyperbilirubin is if the patient is hypovolemic, and then it's just concentrated urine. So another way to think about jaundice is kind of the two H's. Is this heme or is this hepatic? And in this case, we talked about how initially both were plausible, but hepatic is the much more common of the H's to cause jaundice. And within the hepatic bucket, you can ask the question, is this an intra or is this an extra hepatic etiology? And to make progress on that, you can use the degree of liver enzyme elevation. So as an example, if you have a higher AST and ALT, that points more to an intrahepatic process because there's no AST and ALT in the extrahepatic biliary tree. You can also use sodium as the clue because most extrahepatic disease involves stones, strictures, tumors, which do not cause hyponatremia, whereas intrinsic processes are associated with hyponatremia. And you can also use the degree of alk-phos to clue you into whether this is intra or extra, but you have to be a little bit careful because you often think of alk-phos as, you know, indicating that this is an issue with the biliary tree and an extrahepatic issue. But Robbie taught us that you can actually see a high alk-phos with infiltrative intrahepatic disease processes. And the reason is that, you know, we did a visualization of the biliary system, you know, is like microscopic and kind of lives in the liver diffusely. So then when we got to the labs and we saw that the patient had hyponatremia, we learned from Reza that you want to immediately think of is what is sodium's best friend, and that is glucose. And so you want to correct sodium for the degree of hyperglycemia. So for every 100 rise in glucose, you want to increase the sodium by 2. And you can think of hyponatremia as hypoosmolar, isoosmolar, or hyperosmolar. The most common bucket is hypoosmolar hyponatremia. Generally, the symptoms of this are nausea, confusion, seizures, and the fact that this patient did not have those symptoms tells us about the chronicity. So we were thinking this was most likely a subacute process because there were no symptoms. So to work up hyponatremia, you first want to look at the urine sodium, and that clues you into whether this is an ADH, whether ADH is on or not. ADH concentrates the urine. If the urine osmoles is high, you want to look at the urine sodium. And just going through the pathophysiology, if you have, you know, decreased effective blood volume, that activates the RAS system, which retains sodium and lowers the urine sodium. So we were concerned for a hypoosmolar hyponatremia with a high urine sodium and osmolality, and the differential or the causes for that included adrenal insufficiency, hypothyroid, renal insufficiency, cerebral salt wasting, and SIADH. I'll jump to the discussion we had about isoosmotic hyponatremia, and Sammy also kind of walked us through the differential here, which can be both a hypo and a hyperosmolar process. So you have kind of two happening at the same time. Also hypertriglyceridemia, which can be from, you know, a familial hyperlipidemia syndrome, B-cell dyscrasia, things like that. And then quickly going to SIADH, a quick kind of approach you want to go through is you want to make sure there's no physiologic stimulus like pain, review medications that can cause this, and then look for pathologies that can cause SIADH, like small cell cancer, pneumonia like Legionella, and then CNS disorders, and then granulomatous infections. And then lastly, I'll cover, Robbie taught us about diffuse infiltrative liver disease. And the first question you want to ask is, are you worried about a local process alone, or is there evidence of systemic infiltration? So some examples of kind of local causes could be fibrosis in the case of cirrhosis, fatty infiltration, so non-alcoholic steatohepatitis and acute fatty liver disease of pregnancy, and then glycogenic hepatopathy. So a lot of teaching, but I'm definitely gonna have to go back and re-listen to some of this kind of amazing case discussion. So thank you, everyone.
Absolutely superb. So good. Thank you for that great recap. Thank you, Sammy, for an incredible case. The chat's on fire, and a delight to reconvene here, Prof. Rez, after 2 weeks of missing it. So nice to see you here all. Bye.